Section 2.5 is health plans and managed care plans specifically. In this course, we're going to address the various types of managed care health plans and the requirements that managed care health plans have for payment. Today, more than half of all Americans who have health insurance are enrolled in some kind of managed care plan. Managed care plans have agreements with certain doctors, hospitals, and healthcare providers to give a range of services to the plan members at a reduced cost. These plans usually include provisions for utilization controls such as pre-certification for admissions and high-dollar outpatient procedures. Types of managed care plans, along with their definitions, are as follows. Health maintenance organizations, or HMOs. These are health plans that have management responsibility for providing comprehensive healthcare services on a prepayment basis to voluntarily enrolled persons within a designated population. HMOs supply the beneficiary with a directory of physicians from which to choose a primary care physician, also known as a PCP. This physician coordinates the beneficiary's care, which means that generally the beneficiary must contact their physician to be referred to a specialist or obtain prior authorization for non-emergency hospital services. Under an HMO contract, the plan only covers approved services provided by HMO providers, which can include hospitals, independent laboratories, and many other types of providers. If the patient goes outside the HMO provider network, or what is considered out of network, the patient is responsible for the total charges. In network and out of network. A group of providers that have a contract with a health plan and agree to accept a plan's contracted rate as payment in full for services. If a patient goes outside of the network for care, they will likely pay more. Medical providers join networks to increase patient volume. These health plan networks offer policies to employers and individuals that steer business to in-network providers. The incentives include lower copayments, lower deductibles, or lower premiums. Provider directories are distributed that identify the preferred providers in the network. These directories are given to patients when they purchase their health insurance and receive their member ID cards. In exchange for increased patient volume, providers give the health plans discounts on their bills. By signing a contractual agreement, the healthcare facility becomes an in-network provider. The patient's coverage level is determined based on whether he or she uses network or contracted providers. The highest level of reimbursement is paid if the patient uses an in-network facility. In comparison, if a patient receives services at a healthcare facility that is not contracted with his or her managed healthcare plan, his or her health plan will pay out-of-network benefits. The benefit impact can range from a higher percentage coinsurance to zero payment, resulting in higher patient payment responsibility. Disclosures, notice and consent, and estimates must be given to patients before billing out-of-network cost sharing to patients depending on the out-of-network provider specifics and state and federal regulations. In-network versus out-of-network benefits must be tracked as part of payment posting to ensure that patient liabilities are properly stated, provided in writing ahead of furnishing the items or services, and collected in accordance with state and federal regulations. Out-of-network status must be explained to patients during pre-service processing for scheduled patients and at the time of service for unscheduled patients. This allows patients to make informed decisions about where they obtain their healthcare services. Patients who elect to receive out-of-network services must be asked to sign a specific notice and consent form that clearly states their acknowledgement of out-of-network services and their agreement to pay for the difference between in-network and out-of-network patient liabilities. Preferred provider organizations, or PPOs. These are an arrangement whereby a third-party payer contracts with a group of medical care providers who furnish services at lower than usual fees in return for guarantees of certain volumes of patients. Participating providers agree to abide by management and other procedures implemented by the PPO and agree to accept the PPO's reimbursement structure and payment levels. PPO coverage permits members to use non-PPO providers, although higher levels of coinsurance and/or deductibles routinely apply when services are provided by non-participating providers. Exclusive provider organizations, or EPOs, are a form of a PPO in which a very select group of providers is chosen to provide benefits to one or a very limited number of entities, usually a single employer. For example, beneficiaries covered by an EPO are required to receive all of their covered services from providers that participate in the EPO, similar to an HMO. If the patient goes outside the EPO provider network, or what is considered out of network, the patient's responsible for additional cost sharing, and the convening provider must issue a notice and consent to the patient prior to furnishing items and/or services when applicable under state and/or federal regulations. Point of service plans, also known as POS. Healthcare insurance, these are healthcare insurance plans that allow members to select providers either in network or out of network. Beneficiaries are enrolled in an HMO, but they have an option to go outside the network for additional cost. The primary care physicians in a POS plan usually make referrals to other providers in the plan, but in a POS plan, members can refer themselves outside the plan and still get some coverage. If the physician makes a referral out of the network, the plan pays all or most of the bill. If the patient wants to use the provider outside of the network and the services covered by the plan, the patient will have a higher coinsurance responsibility, and additional notice and consents may be required in accordance with state and federal regulations. Medicare Advantage plans. The patient continues to pay his or her monthly Part B premium to Medicare, and in addition, the patient may have to pay a premium to the Medicare Advantage plan for extra benefits that it offers, which could include prescription drug coverage. Patients who join a Medicare Advantage plan generally get their entire Medicare covered health care through the plan. Medicare Advantage plans include the following plan types: Medicare Health Maintenance Organizations, or Medicare HMOs, preferred provider organizations, Medicare PPOs, or private fee for service plans. There are also Medicare Special Needs plans. Medicare Advantage plans replace Medicare's traditional fee-for-service plans. Patients who join a Medicare Advantage plan will receive a health plan card from the plan they select, and this card must be used to access healthcare instead of their Medicare card. The member still needs to provide their Medicare number for required shadow claims for hospital billing, but most plans provide an extra benefit and lower out-of-pocket amounts than original Medicare. But with some plans like HMOs, patients may be required to see physicians who belong to the plan or go to certain hospitals to receive covered services. Other less common types of Medicare Advantage plans that may be available include HMO point of service plans. And this is an HMO plan that allows the beneficiary to obtain some services out of network for a higher cost, just very much like the point of service plans that you would find under a commercial plan. Medicare Savings Accounts, or an MSA plan, is a plan that combines a high deductible health plan with a bank account. Medicare pays the plan, and the plan in turn deposits money into the beneficiary health spending account, usually less than the deductible. The beneficiary can then use the money to pay for the healthcare services during the year. Part D prescription coverage is not included. However, MSA enrollees can join a standalone Medicare prescription drug plan, and the Part B copays will count towards the out-of-pocket spending limit. Medicaid HMO plans. These are HMO plans available only to patients enrolled in the state Medicaid program's medical benefits. In many states, people covered under the Medicaid program are required to join managed care plans. Medicaid managed care plans focus on preventative health care and provide enrollees with a medical home for themselves and their dependents. Medicaid managed care plans must ensure that recipients have access to all medically necessary services that are covered by Medicaid, but use the HMO managed care concepts to coordinate the care for utilization management. Consumer-directed health plans. These specific set of health insurance arrangements in which these are specific set of health insurance arrangements in which individuals have high deductible health plan coupled with a personal health account that they can use to pay that this personal health account can be used to pay for health expenses not covered by insurance. A high deductible health plan is an example of a consumer-directed health plan. Consumer-directed health plans are typically attached to a health savings plan, which allows the employee to save pre-tax dollars in an account which can be used to pay for the higher deductible and co-insurance liabilities. An advantage of these accounts is that there's no requirement to spend the funds within a given calendar year, and any remaining funds go to the employee should the employee leave their current employer. Some of the specific managed care requirements. The various tools and how they're used to manage utilization are listed below. Pre-certification, pre-authorization. These are routinely required for elective hospital admissions, so concurrent reviews can be planned and discharge planning can be started on high-dollar outpatient services, including surgery, to monitor and or control utilization by evaluating the appropriateness, necessity, and the quality of the requested services. Referrals. These documents are completed by a primary care physician to notify an HMO insurance plan that he or she is sending a patient to a subspecialist or specialist for medical care beyond the scope of the primary care physician. The referral notifies the insurance that the primary care physician has recommended and is coordinating this care. Notification. This term is talks about a requirement whereby providers notify the insurance plan that an insured patient is requesting medical services. Insurance companies usually require notification so that their case management can provide utilization management services as required. Site of service limitations. Many managed care plans have developed care plans for common diseases and procedures. The care plans include appropriate settings for care and will only pay for services in an approved setting. An example would be that certain surgical procedures will only be paid as an outpatient service, example, like a colonoscopy, cataract eye surgery, appendectomy. Another example is Medicare inpatient only list. It lists the procedures that Medicare has identified as only reimbursable when provided in an inpatient setting. For an example, exploratory heart surgery, removal of the colon, incision of brain tissue. Discharge planning. Care plans require that discharge planning starts as soon as the patient is admitted. This planning includes determining the expected outcome of the patient's treatment, so resolving the special post-service needs will not delay the patient's discharge. Post-service special needs can include obtaining durable medical equipment like crutches, walkers, wheelchairs, hospital beds, etc. But they can also include rehab services like physical, occupational, or speech therapy. It could also include home health care, skilled nursing facility or SNF placement, and nursing home placement or hospice services, and other things. Care management. Care management is managing the utilization, managing utilization is a critical component of managed healthcare. Case management is a program which seeks to ensure the appropriate levels of care are provided based on the patient's condition. From the health plan side, the plan compares the request for care with community standards of care for similar cases. From the provider side, case managers compare the physician's documented treatment plans to the health plan requirements and provide relevant information to both the health plan and the physician, which accurately depict the patient's needs and the services ordered. Case management example 1. The case management nurse is responsible for gathering information including diagnosis, types of hospital care, medical, surgical, etc., ordering physician, plan procedures, expected discharge date, post-discharge needs, and any other clinical information important to the case. The collected data is then reviewed and a decision is made as to whether the care is medically necessary and also the appropriate setting for the care is established. The managed care health plan authorizes a length of stay and will not pay for services beyond the approved days unless additional days are requested and authorized. Another example of case management. If approved, the case management nurse monitors the case to ensure that all services are provided in a timely manner. Patient education needs to be provided. Discharge planning is completed, including ordering any required home services. Utilization review can be done prospectively prior to the service, concurrently at the time of service, or retrospectively after service. Another example of care management is retrospective reviews are important to determine whether the healthcare services provided were reasonable, necessary, and were furnished effectively in the appropriate setting. These reviews also confirm that complete diagnostic and procedural information is included in the chart. The final care review determines that the established quality standards are met. Key points. So, some of the things we've talked about. Managed care plans have agreements with physicians, hospitals, and other healthcare providers to offer a range of services to plan members at a reduced cost. Managed care plans include the HMO, PPO, EPO, POS, the consumer-directed health plans, Medicare Advantage plans, and Medicaid HMO plans. Managed care health plans use prior authorizations and utilization management review procedures and tools to determine if care is medically necessary. These procedures and tools include things like pre-certification or pre-authorization, referrals, notification, site of service limitations, case management, and discharge planning. Question time, quiz time. Which option is not a specific managed care requirement? Is it referrals, notification, preferred provider organization, or discharge planning? The answer of which is not a specific managed care requirement is preferred provider organization. Remember, a PPO is a form of managed care, which is the closest to an indemnity plan. A PPO is not a specific managed care requirement. It's a health plan where the employer health plan and the health plan contract to purchase healthcare services for covered beneficiaries from a selected group of participating providers. That concludes section 2.5. We're going to move on to section 2.6, price transparency. In this course, we'll address the principles of price transparency, the role of price estimates in the patient financial care, and how pricing information is used to prepare and present price estimates. Getting to price is a challenge for both patients and providers. Price is defined as the amount actually paid by the health plan and or the patient for specific service. This is very different from either cost or charges. The price a patient pays for healthcare services depends on the healthcare insurance that he or she has or doesn't have. If a patient has health insurance, generally the patient shares in the total price in the form of deductible, copayment, or coinsurance requirements. In addition, health plans often contract with hospitals, physicians, and other healthcare providers to form a provider network for its subscribers. The price for in-network services will be lower than the price for the same services in an out-of-network setting. With the advent of high-deductible health plans, consumers and patients are requesting price and quality information as part of determining where they'll receive care. Therefore, providers have developed processes and employed technology solutions to respond to these requests. The first component of a pricing determination is a verification of the patient's insurance eligibility and benefits. Most often, this information is obtained through real-time electronic transactions with the health plan. The second component of determining a price is to identify the service or test involved. The clinical information needed to determine a price includes the services or tests, the patient type, diagnosis and procedure codes, and any anticipated follow-up care. The health plan response to a verification inquiry typically contains the following information, which is needed to develop a price estimate. There's a confirmation of the consumer or patient's eligibility for coverage, the details of coverages and limitations, including site or service restrictions such as eligible lab draw locations or a number of therapy visits authorized. There also needs to be a network status, authorization, or referral requirements, and normally there's a detailed status of contracted deductible, copayment, coinsurance, and maximum out-of-pocket limitations. Constructing a price estimate. Your organization may have developed a technology solution to create a price estimate that's compliant with state and federal requirements. If not, you must have a documented workflow or other tools to guide you through determining information needed to respond to a price estimate request. Regardless of the methodology used, this is an example of steps involved in the surgical case estimate for a total knee replacement for a patient covered by a commercial managed care plan. The first step is to verify. Verify that the insurance coverage that will be used for the service, including eligibility and benefit details, and document the current status of the deductible and any coinsurance amount. The second step is to identify. Identify the contract terms between your organization and the health plan. For example, are inpatient cases paid by MSDRG, a percentage charge, a preset case rate, bundled services, etc. The third step is obtain. Obtain the total charges for the encounter. Concurrently, identify any additional co-providers who may be involved. For example, people like anesthesia or other surgeons or assistant surgeons. And note their in-network or out-of-network status in compliance with state and federal regulations. Next, you'll need to apply the benefit information to the charge information. Apply the payment methodology to the total charges. The price estimate should be presented in a format that's easily explained to the patient. In addition to the price estimate for hospital services, the financial conversation should also inform the patient that physician services are or are not included. The in-network or out-of-network status of these physicians should also be communicated. The price estimate and financial assistance. A component of the price estimate conversation should be a discussion about available financial assistance programs, including Medicaid eligibility, screening, or other financial assistance. If the patient becomes eligible for financial assistance based on your financial assistance policy, remember that when 501R applies, the rules dealing with the amounts generally billed apply as well. There's more about this in section 4.6 of this program. Key, key points. The importance of the application of price transparency principles to the development of information necessary to successfully and compliantly complete a financial responsibility conversation with the patient. While healthcare is different from commodity purchases, consumers do expect providers will provide a reasonable estimate of the out-of-pocket costs related to the order item and/or services. Coupling the estimation with the patient financial communication best practices allows providers to provide high-quality, compliant level of financial care to patients. The components of pricing determination include verification of the patient's insurance eligibility and benefits, and identify the service or test involved. The health plan response contains elements needed for price estimation. Quiz time. What is the first component of a pricing determination? Is it 1, identify the service or test involved, 2, verification of the patient's insurance eligibility and benefits, 3, inform the patient that physician services are not included, or 4, use a worksheet or tool to determine the estimate? If you answered number 2, that's correct. Most often, this information is obtained through a real-time electronic transaction with the health plan. The health plan response to a verification inquiry typically contains the following information, which is needed to develop a price estimate. It's a confirmation of the consumer or patient's eligibility for coverage. It details coverages and limitations, including site or service restrictions such as eligible lab draw locations or a number of therapy visits authorized. And it also provides network status. This concludes section 2.6.